Thank you for the kind introduction and being able to come along and speak to you today. I'd just like to back up Nicole's sentiments about the comfort cohort and what a really important resource that's going to be for New Zealand going forward. It'll mean we've got these stored samples and stored data of all these people with IBS and without IBS. So if there are questions from industry, from science that these samples can answer, it's really going to allow that depth of knowledge to expand. I'm interested in the microbiome from a different reason. I see the microbiome every day when I go to work and do colonoscopy. So I have a slightly different view on the microbiome than many of you may have. What I want to talk about today, though, is a clinical study which was first presented yesterday at a Zespri meeting. This is the first time it's been presented outside of Zespri. And I think it's very interesting for a number of reasons. Firstly, it's about a New Zealand food. Secondly, there's a lot of talk about regulation within this, which I think will fit in nicely with the talks that we have after lunch, and hopefully will bring together some of the aspects around gut health and making a claim in that area. So this is the effect of Zespri Green Kiwifruit on digestive and gut health functions. It's a multi-centre, multi-country trial, but these are just the New Zealand data that I'll be presenting today. The project team includes Professor Giovanni Barbara from Bologna in Italy, Professor Shin Fukudo from Japan, and we are looking at the study in different areas around the world, replicating the study. And at the moment, the Italian study is half recruited or 2/3 recruited, and the Japanese study is about to start. Lindley Drummond's done an amazing job with this, because if you're going to do a study and hope at the end you may be able to make a health claim with this and other data, you have to make sure that you do it exactly the right way. And I'll go through that in a minute as I go through the study. And Juliet Ansell has also worked very hard from a Zespri point of view to make that happen. However, the engine room of the study, the people who have done the work is Plant and Food Research, and in particular Sarah Eadie, who's done an amazing job with her team. And the statistics were done by Barbara Kuhn-Sherlock, and I'm very grateful for her because she hasn't had long to do them before the two talks we've done this week. No one tends to do disclosures here. In medicine, we always disclose any potential conflicts of interest that we have, so there are mine that are relevant to this. So as you've heard already, constipation is common. It leads to very uncomfortable looking pictures on people's faces, as we saw from a talk just before morning tea. But because it's common, it's something that is often targeted by foods to potentially have a benefit in that area. It can occur by itself, in which case we would call that functional constipation. But when it occurs with abdominal pain, that may qualify as irritable bowel syndrome, which is very common. I quote my patients, 1 in 6 women, 1 in 9 men have IBS. This has a significant effect on physical and psychological well-being. It leads to impact on school and work absenteeism and presenteeism, where people are present at work or school but aren't performing very well, so they're not at their best in doing what they can. And we also know that if we have effective therapies for this, this can lead to an improved quality of life, and we can help people, so it's a really good target. As I mentioned, gastrointestinal discomfort, on the other hand, is more around abdominal pain, bloating, these other symptoms such as these. And why functional constipation and irritable bowel syndrome are so important is that if you want to make a health claim with EFSA in particular, they have nominated these two diseases, or syndromes if you like, as the groups or populations that should be studied. And if differences and effects are shown in that population, they can be extrapolated to the whole community. So it's quite a different concept, I think, to some of the other areas that we're dealing with today. We already know quite a bit about kiwifruit and the gut. I mean, we all know that our grandmothers told us that we should have 2 kiwifruit a day to keep regular, but unfortunately the science and regulators don't accept my grandmother's word when it comes to making a health claim. But there are published studies out there already, which you can see here. And the first one was from Elaine Rush and others in constipated individuals who are elderly, and that study showed an increased effect of laxation or bowel frequency, improved ease of passing of bowel motion, and other reductions there. There are 2 studies from Asia, one from Hong Kong, one from Taiwan. One showed increased colonic transit, also improved bowel frequency, and also some other ones that are showing improvements in discomfort or pain. And while these are good studies, they were well done to the purposes that were needed at the time to show that, unfortunately, when it comes to making a health claim, it's a completely different story. You have to have an extremely well-phenotyped group of participants. You have to use validated questionnaires and endpoints that are accepted by regulatory bodies as being important. And while these studies did a good job, they didn't have that rigour around them, which would now be required. So that's why Zespri were in particular interested to do a study with more rigour that would potentially enable them to go to a regulator and have a health claim. So it's important to demonstrate that kiwifruit are effective for a number of people. As I mentioned before, we may all know that it has this effect, but it's good to know scientifically it's been proven. And for healthcare providers, many of whom will be talking to patients or people with constipation about their symptoms, again, it's very important for them to know that there's high quality science underlying it. And then for Zespri, who want to be a good corporate citizen, they only want to have the best high quality research that backs up their product. So all of us have a stake in this, if you like, and it's important that we work together to try and prove these things. And when it comes to communication, I think this is something that I'm not sure it's been covered today, but if you think about Zespri, for example, they've got 3 different areas that they do health research in digestive health, which is of course the most important, but there's other things such as vitamin C and metabolic health that evidently have some importance as well. And if they have this knowledge and science that's sitting there, they may wish to talk to their consumers who are there, but clearly the ability to do that may be limited. So the way that they do that is by running symposia, having health communications, funding science to inform health practitioners, and that's where I was yesterday, giving a similar talk to a group of these people from around the world who have come to hear about the science that Zespri do. That then allows those people to evaluate the science, form an opinion, integrate it with their knowledge already, and then communicate that on Zespri's behalf, if you like, to health consumers. And that's a reasonable and effective way of spreading knowledge about a condition and potential treatments of a condition to the general population. Of course, Zespri can communicate directly through nutritional data. They can make claims around vitamin C, which is part of what's going on, and that's easy. But when it comes to making a health claim, this is really where it gets a lot trickier, as you know already, and you'll hear later today. The level of evidence that's required is much, much higher. So if Zespri wish to do this, this is where really the work has to go in. So moving on to the study now, which is the effect of Zespri Green Kiwifruit on digestive and gut health function. So the hypotheses that we had were that the consumption of 2 Zespri Green Kiwifruit per day would improve bowel motion frequency by 1.5 complete spontaneous bowel motions per week. And that consumption of 2 green kiwifruit would also lead to improvement in gastrointestinal discomfort, and that they'd be safe and well tolerated. This was the study's design, so it was a randomised single-blinded crossover design. Now, the problem with a whole food is it's really hard to tell someone that this is a kiwifruit when it's not. It is a kiwifruit. You can't blind a whole kiwifruit and tell them it's an apple or something else. So as investigators and statisticians, we were blinded, but it is impossible to blind a participant to a whole food. So we were not able to do that. But what we did is we used a positive control. So participants were randomised to either receive 2 Zespri Green Kiwifruit per week for 4 weeks, or psyllium in the form of Metamucil, 7.5 grams or 6 grams of psyllium fibre as a positive control, so that we could then compare the differences between something we know works and something we think might work according to our hypothesis. Participants were washed out for 4 weeks and then switched over to the other arm, and then were followed up subsequently. Inclusion criteria were adults with a BMI 18 to 35, and there were 20 in each group of functionally constipated, IBS-C and healthy participants. And the exclusion criteria were ones that you would imagine, people with symptoms that may suggest more sinister pathology, other chronic medical conditions, allergy to kiwifruit, or people who just weren't able or willing to stop taking a laxative over this period of time. This is a schedule of assessments. I'll go through this pretty quickly. Along the top you can see the different interventions that we had. The blue diamonds are the gastrointestinal rating, symptom rating scale, which is a validated means of measuring gastrointestinal symptoms. I'll show you that in a moment. We did diet diaries throughout to ensure a habitual diet that didn't change. We measured bowel motion frequency, not only how many bowel motions you've had, but whether the bowel motion that you had was complete, whether it was spontaneous, whether it was complete and spontaneous, whether you had to strain or not, and then we got you to describe it with a lovely picture that I'll show you in just a moment. We then looked at quality of life and a whole lot of other measures, and the key thing I want to say about this is that those measures are validated questionnaires used in the right way and by the right people, so that it means that when this is looked at, it'll be seen as being assessed in the appropriate manner. We also used something called SmartPill to look at colonic motility. We heard about radio-opaque sitz marks earlier. This is a new technology that plant and food have, which I'll mention in just a moment. So the clinical assessments, the primary outcome were these daily stool habit diaries, number of complete spontaneous bowel motions, and there's this range of other secondary outcomes that we were looking at. This is the gastrointestinal symptom rating scale, and these are the different domains that we have, and I'll present the data later in some of those domains, but you can see from this the sorts of symptoms that people are asked about and whether they were present or not. This is the Bristol stool chart. This is the thing you've been waiting for so long. So here you can see at the top is type 1. This is a very constipated, hard, pellet-like stool. And type 7 is liquid, and you can see the gradients in between. It's good this is before lunch, isn't it? So it's great. So, if someone has IBS-C, they have predominantly type 1 and type 2 bowel motions. So we've got a very scientific way of assessing this. This is a SmartPill motility monitoring system. So people swallow this pill and it goes through them over 5 days. And over this time it detects pH, detects temperature and also pH and pressure. And it's beamed wirelessly from that capsule to a data recorder. The data recorder is then downloaded onto a computer and the data is displayed. You get a lovely display like this. The red along the bottom is the pressure that's occurring. The blue line is the temperature, so it's going from room temperature to body temperature, and then when you pass it, it goes to water temperature. And then in the green line, which is the really fascinating one, is luminal pH. So you can see luminal pH in the gastric phase drops dramatically as it hits the stomach, goes straight up as it hits the duodenum and bicarbonate's produced, and then you get a normal pH, then drops again in the colon with short-chain fatty acids until it's finally passed. So as opposed to SITS marks where you get a yes or no at a point in time, you get an exact number, the exact time of colonic transit, which is fascinating. In safety, we looked for standard safety concerns, as we mentioned, and the statistics were, as you would imagine, we're comparing healthy controls, IBS-C, and we combine those groups as well. So the results. So a lot of people screened. 80 people were screened eventually. 220 said they'd be keen, but then they found out about the study and decided they weren't so keen. 60 of those participants ended up being randomised, 20 to each of the groups, and of those, about half of each group underwent SmartPill. 2 dropped out in the IBS-C group very early on and were included for subsequent analysis. These are the baseline characteristics of the group. Unsurprisingly, the majority, in fact, all of the IBS-C patients were women, and that's probably because women are more willing than men to take part in clinical trials of this nature, and also because IBS-C is much more common in women than men. The other point I'll note there is that the IBS severity scale down the bottom, the IBS-C group had really very mild severity. That 190 is quite a low number, and this is what we wanted. We didn't want people with terrible, nasty, severe constipation going into this. We wanted people who had mild constipation who reflected the general population. So here's the primary outcome for psyllium, and I'll show kiwifruit in just a moment. I'll just orientate you to the graph if I could. So on that vertical axis we have the number of complete spontaneous bowel motions per week. Then we have the data grouped by healthy controls, by functional constipation, IBS-C, and then those combined groups. In the blue we have the lead-in period before the intervention, and in the red we have the intervention with psyllium. And what we can see here is that there's a difference in complete spontaneous bowel motions between nothing and psyllium. We can see there for the constipation, the IBS-C and the combined group, but the combined in the IBS and the functional constipation group is statistically significant. These are the data for kiwifruit, so we can see that there is an increase in all of the groups, but it's only significant in the IBS-C group and in the combined group. And these are really very important data, and the reason is that there's been an increase in 2 complete spontaneous bowel motions per week. Now the FDA says if you have a treatment, it's said to be clinically effective if you've had an increase in 1 complete spontaneous bowel motion per day. So this well and truly hit the endpoint and was a positive study for this, which we're very excited about, obviously. Although I did say to Zespri yesterday when I stood up, I'd have to tell them if it was negative as well, but they were happy it was positive, believe me. Looking at the secondary outcomes more around comfort now, this is straining. So this is, if you had a number of 2, you strain with every bowel motion, 0 with no bowel motions. And again, psyllium helps with straining. It's easier to pass a bowel motion if you have psyllium in your diet. And for kiwifruit, we saw the same change, a significant improvement in straining that occurred with this intervention. This is the Bristol stool chart. I told you I was showing it for a reason. These are the Bristol stool chart data. And what you can see here is that with psyllium, you're getting an increase, particularly in the IBS-C group and in the combined group, in the number or the type of bowel motion. So it's becoming softer or looser, if you like. And again, for kiwifruit, we're seeing a similar change here where you're getting a significant softer consistency to the bowel motion than you would otherwise imagine. One of the secondary outcomes was constipation as defined by the Rome 3 criteria. Now, this is, are you constipated at a point in time, yes or no? So it's a binary outcome, and the study was never powered to show a difference here, but we measured it because it's a validated tool, and we wanted the data to see what sort of signals were present. So for psyllium, although there was a difference between the lead-in period and the treatment, it was not statistically significant. Rather surprisingly, though, for kiwifruit, we did show statistical significance for the combined group, which was a nice surprise. We weren't expecting that, but suggests again that this was a consistent effect. We looked at gastrointestinal comfort using the GSRS and looking at constipation, looking at all the groups. And you can see here that for psyllium, constipation certainly improved dramatically, although not much in the way of other changes there. For kiwifruit, we got changes across a number of different domains, some of which you may suggest would be difficult to explain why someone would have less reflux symptoms, but it may well be that if you're able to keep the bowel moving forward in a proactive way, the other upper gastrointestinal symptoms may improve as well. We looked at quality of life, and again for psyllium, it was effective, and also effective again for kiwifruit. And some of the data there for transit time. So this is using the SmartPill. This is colonic transit. So on the red, you can see the psyllium data, and in the green, we can see the kiwifruit data. Now, we didn't do colonic transit in the lead-in period. We only did it during the treatment period. And what you can see there is that certainly the green bars are taller than the red bars, suggesting that colonic transit time was longer in kiwifruit than with psyllium. But I'll tell you now, there's no statistical difference between those results. So while there is an effect on colonic transit, it doesn't appear to be as great as with psyllium using the SmartPill technology. So there's still more data to follow. We've got data on fecal microbiota. It'll be fascinating to look at the differences between fecal microbiota in Japan, in New Zealand, in Italy, and look at differences that occur there. We've got data on profile of mood score, talking about the gut-brain axis to see are there data occurring there that could be useful. We've got the food diary data and vitamin C measurements as well, which may also be a covariate or something that's useful. So in conclusion, ladies and gentlemen, I think we've shown in this study, in this cohort, that consumption of 2 Zespri Green Kiwifruit daily improves bowel motion frequency in constipated individuals by 2 complete spontaneous bowel motions per week on average. And as I mentioned earlier, the FDA recognises an increase of 1 complete spontaneous bowel motion per week to be clinically significant. So this is exciting data for Zespri. In addition to that, we've shown some improvements in gastrointestinal comfort. So consumption of 2 Zespri Green Kiwifruit improves gastrointestinal discomfort in a range of different domains and different symptoms that are mentioned there, and that equates with an improved quality of life as well. And the other thing, which is really important, and certainly as a doctor where we're dealing with drugs, there were no concerning safety signals. So most importantly, the healthy controls didn't get diarrhea, which people often ask, if you have Zespri Kiwifruit and it improves constipation, will you get diarrhea? We didn't see that in the study. And also there were no other treatment-related adverse events. Now, no study is perfect, and there are limitations with this study, which I'll mention now before I finish up. Firstly, patients were not blinded, or participants were not blinded. And as I mentioned before, you cannot blind participants to a whole food study unless we could put a peg in, actually. We could put a tube into their stomach and feed them into that, but ethically that would be difficult to get over the line. So it's very difficult to blind people, but inevitably that will mean people will be eating kiwifruit, knowing they're eating kiwifruit, and they may have preconceived ideas about what effect that could have, and that may influence the results. However, we did use validated questionnaires, and we also used a positive control and showed that there was, I haven't done the comparison there, but there was no difference between the positive control and the kiwifruit. Also, we had relatively small numbers in each arm, but in saying that, the study was powered appropriately and met its endpoint based on those numbers. And again, there's little mechanistic data here, and I'm happy to have a conversation about the mechanistic data, but understanding that will be very important. There are a number of future directions, there are other places to go, and certainly EFSA claims may be on the cards with a lot of other data to follow. And I'd like to thank the various people and groups who helped with the study. Thank you very much.